So my first case study is of Jorge Arguellero, a 54-year-old Hispanic man referred for uncontrolled hypertension, and he is also diagnosed with type 2 diabetes. Right now, his A1C is 6.8%, and his serum glucose is 120 milligrams per deciliter. For his assessment, I would obtain a repeated blood pressure monitor. I'd also want to get his height, his weight, his BMI, his weight history, and even a pretty in-depth diet history as well. I know that he talks about eating flour tortillas, refried beans, rice, and beef with very few fruits and vegetables, but he doesn't talk about portions or sodium. And I would want to ask him how those foods are prepared, if they use a lot of bouillon or seasoning packets. But I also want to get to know him a little bit to see who's preparing the food, what the kitchen looks like, the budget that they have, the food security that they have, also the preferred language, who shops, who cooks, what that looks like, if he even knows what's going in the food that he's having, or he's just coming home from working. So I want to build that rapport, get to know those details, while also wanting to get those assessments done as well. His medications as well, he said he has fatigue with one of them, and he takes it 2 to 3 times a week, and he's experienced lip swelling from the Linsipol. And so I wanted to talk to the pharmacist to see, and have him talk to the pharmacist to see if he could change those or what that would look like for him, and just have another update and talk to the person that prescribed them for him. As for the nutrition diagnosis, I would look for the undesirable foods and trying to change those things and add those in, which is changing his eating pattern. So he's reported that he's had a limited intake of fruits and vegetables, and has a lot of food centered around flour tortillas, refried beans, beef, all of those with his hypertension. So I would, for intervention, I'd want to use the dash and plate method approach. So it's not to tell him that his cultural and his foods, like Mexican food, is unhealthy, or to remove all of those things that are important to him. I would show him how meals can be like half a plate of food, such as like the peppers, the tomatoes, the cabbage, the jicama, all of those things, a quarter beans, fish or lean beef, and 1/4 of the corn tortillas. So just kind of reportioning what he has on his plate. So that's what the dash is like, looking at those portions that you can have, not like can have, but that are helpful in meeting goals with this hypertension and with the diabetes. I would also talk about, especially with beans, getting a lower sodium option, or rinsing those beans, not using the bouillons and the seasoning packets, comparing tortilla labels, and also building flavor with lower calorie, not as sodium dense things like cilantro. We can have garlic, we can do chili, we can do cumin, all of those spices that are staples in Mexican cuisine that add a lot of flavor and don't take away from the overall aroma of the meal, and can add to his culture, but still having those things that are like, okay, these are really prominent, how can we cut them out a little bit to help with the hypertension and to work with his diabetes as well. So I want to have a balanced carbohydrate, consistent eating pattern with a sodium below 2,000 milligrams, and also talk to his doctor. And I want to set 2 really small goals of eating a vegetable at 1 meal every single day for like 5 days a week, and just comparing labels on lower sodium options this week if he's the one that goes shopping, or talking to his girlfriend that goes shopping and seeing those things. I think cultural competency requires curiosity instead of assumptions. So I'd ask him what foods he values most, what is most important, whether he wants his girlfriend to participate, what that looks like for him, and just simply asking him where he's at with these diagnoses, and seeing how he is feeling about the effects it's going to have on his normal life. Health equity is also addressing the unemployment that he might have, the medications that he is on, the affordability of the products that he already buys, or the money that they have to spend on these things, how close food access is for them, and transportation. So having recommendations that are within their means and in a way that they can actually utilize the things that we are giving them. I would have them come in 2 to 4 weeks, check the blood pressure logs, see their diet goals, how that's been going, and how the goals that we set are going, and how he's feeling about those things and barriers that he's also faced. I'd look at his blood pressure, his A1C, and his weight is a monitored thing that we'd be looking over, are the things that I would prescribe for him.